we may, and we've got quite a busy agenda. So first, welcome introductions, where we've done some of those introductions, I think. Apologies for absence, Julie.
Julian Ems, Chief Executive. Alex is attending for him, and Tom O'Kane and Susanna Rose. Thanks so much indeed. Any declarations of interest? Right. Okay. The minutes of the last formal meeting, which is on the 10th of March. Any corrections to the minutes, please? Oh, hands up, Graham.
Yeah, I'm going to refer to the next set of minutes, the urgency one. But I think, so far as these, she hasn't raised her hand, but I think Councillor Matic is shown as a public governor. I think she's an appointed governor. Similarly, on the next set of minutes, I'm shown as a public governor, and I'm not. Okay. I'm sure that will be corrected, Graham.
Yes, thank you.
Sorry about that. Okay. Any other changes? All right. Let's go back to the agenda then. So, election results, which enclosed. Julie, do you want to say anything about this? No, it's just for noting. We've already mentioned our new governors. Okay. Right. In which case, on to some of the main items on the agenda. The first one is about CAM's waiting list presentations, and Karen Cridland is kindly going to speak to you. And we've got about 20 minutes for the item. I've asked Karen to be sort of briefish on the presentation, so we've got plenty of time for questions. So, Karen, if you're there, over to you.
Yes, I'm there, and thank you everybody for inviting me today. And those that don't know me, I'm Karen Cridland. I'm the Divisional Director for Children, Young People and Family Services, and also Learning Disabilities. So I have a presentation, but I will run through it very quickly because it's about scene setting. And then obviously what's more important is that I'm here to be able to answer any of your questions. So I'll just share my sorry, there it is, sorry. I was thinking, where's it gone? Where's it gone?
I thought it was only me that couldn't find things on computers, but
no, after 2 years on Teams, you'd think I'd know what I was doing, wouldn't you?
Oh well.
Let me just get it in the right place. Now, obviously, as I'm sharing, I can't actually see any hands. I can take questions as I go through, but also I'll take questions at the end. But if I just whiz through this so I can set the scene. Yeah, you go through and then we'll have questions at the end, I think. Okay, that's fine. So I'm here, my expectations is that it's about clarity about waiting times for our child and adolescent mental health services, and also just to give you a brief overview on the support and treatment that's available for people whilst they're waiting on either the CAMS waiting list or the autism and ADHD waiting list. So I'll just whiz through that. So what I just wanted to present to you all first is what's called the Thrive model, because this is the model that we work within across all our systems. And the reason for showing this to you is to show that it's not just Berkshire Healthcare that's involved in supporting children and young people with social and emotional well-being or mental health concerns. So a lot of the support that children and young people receive is in what we call the Getting Advice services. So that's in our top left-hand quadrant. And those services tend to be community-led or school-led. It might involve our common point of entry, but they are children that need some support about social and emotional well-being, as opposed to those children and young people with specific mental health services. Our school nurses are involved in those services. There's online digital support there. So the vast majority of children and young people get their support in the community and in school-led services. We move over to the top right-hand quadrant. We're in what's called the Getting Help area. And in the east of the county, Berkshire Healthcare is very involved in this area. We are commissioned to provide what's called these mental health support teams in schools. And we're also commissioned to provide a service that's actually called Getting Help. It's about where children and young people need a little bit more, but they don't have a specific mental health concern. In the west of the county, the Getting Help services are generally provided by the local authority, but Berkshire Healthcare is supportive in terms of providing supervision for the service. Although obviously this is Berkshire, so there's some complexity around here. So in Wokingham, we do provide a service. Where Berkshire Healthcare are much more involved is in what in this Thrive model is called getting more help. And this is where children and young people do have additional needs and specific mental health concerns. So our services that we provide here are our eating disorder service, our health and justice service, our specialist teams that are county-wide, our CAMHS Tier 4 service. And then going on to the bottom left-hand corner, this is called Getting Risk Support. So these are children and young people who are in crisis. So that's where our rapid response service and our crisis, and I'll come on to that in a bit more detail, are more involved. So I just wanted to show you the picture of the fact that this is providing services is something that we do with our colleagues in the local authority, our colleagues in the voluntary sector, and an independent provider. So it's a whole system support. So just very quickly then, the services we provide are the locality specialist community teams, an anxiety and depression pathway, which is county-wide, 3 locality Getting Help teams and 3 school-based mental health support teams in the east. We provide an all-age eating disorder service that's county-wide, a rapid response service that's county-wide, a health and justice and child and care worker service, and then our Tier 4 service and a common point of entry. So those are Berkshire Healthcare services. I've got some quite complex graphs here, and I think these are probably where you'll probably be wanting to ask me some questions, but I'm just going to whiz through the key points here rather than spending time on the graphs. Our referrals have increased substantially since the pandemic. So pre-pandemic, our average referral rate was 622 per month. For 21-22, our average referral rate was 918 per month, so we've had an increase of 47.6%. And of those referrals coming in, 44% for our new neurodiversity service and 56% are for our mental health services. So I spoke very quickly about rapid response. Our referrals for the crisis team were which is the rapid response team, were up by 7% this year. Not only have we had an increase in referrals, but generally across all services, we've had an increase in the acuity and complexity of cases. Now, what we call our core CAMHS service, which is our specialist community teams, again, our referral rates have increased. They've gone up by 27%. Which is resulting in longer waits for first appointment and for second appointment. This is quite complex, this graph, but the yellow line is our first appointment wait, which we're currently waiting at 10 weeks. But our second appointment wait, which is the blue line, as you can see, dipped, but has increased substantially to about 30 weeks. The story, if I'm honest, is the same across all the services. So this is our eating disorders service. We had a huge increase of referrals as there was nationally during the pandemic. They've gradually leveled off. But if I tell you, before the pandemic, we had 13 referrals on average per month. During the pandemic, it was 19. It's now averaging out about 18 per month. Our average wait for first appointment is currently, for urgent appointments, it's sitting at about 7 weeks. Our national standard is 4 weeks. and for a routine appointment, which is this blue line, we're running at about 12 weeks. The autism referrals and the ADHD referrals have also increased substantially. Autism referrals have actually increased by 69% since 2016. I'm not going to, I'll answer questions on autism and ADHD, but it's just for you to know, and some of you I've spoken to about these services. We have received some substantial investment from our 2 CCGs in the East and the West to actually get our waiting times reduced. And we've also got some support from the Trust at the moment to help us, to support us looking at our processes to ensure that we are as efficient as possible. The waiting times are still high. They have been impacted by the pandemic. We're beginning to see a little bit of improvement in our waiting times in ADHD and autism. Whilst children are, young people are waiting for services, or sometimes actually this is what they need, we do have a Sharon, so our support, hope and resources online support for some of our services, which include our neurodiversity service, our eating disorder service and our anxiety and depression. Our neurodiversity service has a helpline, and we run parent workshops for anxiety and depression. We also have for neurodiversity qualified children's wellbeing practitioners and pre-assessment support workshops. In our mental health services, we have CAMHS duty workers who take calls. They're based in our common point of entry, and they can take calls and support there. And children in crisis go straight to our rapid response team, who will see the child or young person on the day. And then just another couple of things to let you know, which I'll run through very quickly. Across our Bob and actually our East Berkshire service as well, we've got a peace pathway which we're running along with our Oxfordshire and Buckinghamshire colleagues, and it's about supporting children and young people who have autism and eating disorders. And then across Bob, our areas of focus are looking at a CAMHS Academy, that we do nationally have concerns and issues about recruitment. And so we're looking at a CAMHS Academy to develop our own teams and our own workforce. We're looking at how we can support children and young people digitally, and we're looking at system and partnership working. And in our Frimley area, we are also doing very similar things, but build up those areas of work. So I think I'll stop there, because I think it's more important that I hear your questions and I'm in a position to answer them.
Karen, thank you very much. Graham Bridgman's got his hand up.
Yep, thank you. Couple of questions. Firstly, you showed a chart in relation to eating disorder, and it was labelled beds. I just wonder what beds refers to.
Oh, no, that's
not
a really good question. Yeah, it's a really good question, because we don't actually have beds either. There are beds. It's Berkshire Eating Disorder Service. But a good question. We should not use
Second one is an earlier slide showed a number of services labelled as the Eastern local authorities, so showing 3 services in each of the Eastern local authorities, a couple of those, and nothing for the West. So I just want to clarify whether the funding you're getting through from what is currently Berkshire ECCG, as opposed to, is more than the funding you're getting through from Berkshire West CCG. So in other words, to clarify differences between East and West, and therefore differences within the ICSs as they come forward, just to understand whether those children and young people in the east of the county are getting a better deal from your services than those in the west of the county.
Okay, I'll just go through, because it's, as we know in Berkshire, it's always a complex commissioning landscape. So the 3 services, so 3 of the services are what's called the mental health support teams in schools, and that funding comes down from NHS England, and in the east of the county, Berkshire Healthcare are commissioned to provide those teams into the schools. In the west of the county, the decision was made for the funding to pass into the local authorities. So the children and young people in the west of the county get the service, but the provision is via the local authority, and the local authority provide the staff. The other service that you talk about is called the Getting Help teams that do the early support. And again, it's not a dissimilar picture. In the east of the county, the CCG decided to commission Berkshire Healthcare to provide that service. That funding comes through the CCG and the local authority. In the west of the county, it's the local authorities that provide that early support. So it's the children and young people get the service, but it's different providers.
Thanks.
Okay, I think Graham, just on your point, I think there is an issue which I think we're all probably interested in, which is about the potential fragmentation of the way we deliver services across Berkshire. And I think I have a view, which I think is shared by my board colleagues, that we need to work with our partners to try and get a standardised approach, because all these differences are causing inefficiency in the system and confusion. And it'd just be nice, maybe we need to get together with all our local authorities and all the other partners to sort of talk about how we get commissioning and of course the delivery of services consistent across the patch. So clearly they will vary depending on the demand and this sort of stuff in different areas, but we need to make it as simple as possible. So otherwise we're spending all our time, redesigning services.
I think we'll all be singing from a very similar hymn sheet on that one.
Yeah, and certainly, Martin, the services will be are behind that view because there are inefficiencies, as you said.
Yeah, and we've got to respect the the political makeup of the county. That's about democracy, but I think we need all to get together to try and make it as consistent with ourselves and with the local authorities and others as we possibly can. Now we've got lots of questions. Brian.
Yes, thank you very much, Karen. My question is about the support whilst waiting, and you listed parent workshops there. I'd be interested in knowing a little bit more about what that entails and how much of a substantial contribution that is to the waiting period.
So it's the parent workshops that we provide. There's parent workshops that we provide for anxiety and depression pathway. It doesn't add to the waiting time. It's about supporting parents to support their young person in their family who has anxiety and depression. So it's actually part of the pathway. We just do it whilst the child is on the waiting list. So it's not adding to the waiting list. It's part and parcel of the care pathways. In the neurodiversity teams, there are parent workshops that are provided. We don't provide them in Berkshire Healthcare. The CCGs have commissioned in the East an organisation called GEMS to provide the support, and in the West it's Autism Berkshire. So again, it's about supporting parents and the young people themselves, and actually that support is there irrespective of whether a child or young person is diagnosed with neurodiversity or not. It is there for support. Does that answer your question?
Yes, indeed it does. Thank you.
Thank you. Tom Lake.
Just to say that while we do have these two different systems in the East and the West, I must say I'm a bit concerned about the mental health support teams being based in the sort of social care environment. But at least it would be very good to understand how they're being evaluated and whether there could be a comparative evaluation of the two approaches. Would be really useful. Perhaps Reading University could get involved in something like that, but it really would be good to learn from that.
Yeah, so the mental health support teams are a national initiative, and we are under national guidelines of what is actually provided. So they work across the country, and they are quite tightly governed in what is provided in terms of how many schools each worker can provide to. What we do in the West in mental health support teams is we provide the supervision to the people who are working in those mental health support teams employed by the local authority.
Okay, Tom.
Yes, thank you. I'm particularly pleased to hear about the supervision because that wasn't clear when we first learned about them. That's really good news. Thank you.
Okay, Tina.
Hi, Karen. I'd like to go to your first graph you show us. It says like, you know, your referrals are high over 1,000 and then in August significantly fall down to like 400. And then it goes up again. I mean, I know people go on holidays, but we shouldn't dip that much down.
We always drop in August. We have a trend that we see annually, and August always drops a lot. Some of our referrals come through from schools, and obviously schools aren't running. So the peaks that we have are generally exam time. So we will have a peak on the run up to exams. We nearly always drop off in August when children and young people aren't at school and perhaps in the family home. And we drop off at Christmas and we rise again in January. So we actually have quite a regular trend annually. So the drop isn't a surprise to us. I know it looks quite dramatic, but it is quite dramatic in August. So we don't have that's the trend every year.
Thank you.
Okay, John.
Right. Apologies for the background, but I can't help that. Firstly, if there's any advantage in having two different models across, is we can at least identify what works particularly well in one, particularly well in another, so that as they converge, and I think we are all 100% about converging, then the model that we can get will be taking the best. What I was particularly interested in is looking at your first slide and prime. I'm assuming I'm correct in thinking the further round you go from the top left-hand corner to the bottom left-hand corner, the more severe the need to provide support. Is that correct, Karen?
Yeah, that is. So the top, you're right, the top left-hand corner is children and young people that need some support. They've got emotional concerns as opposed to mental health concerns. The bottom left-hand corner is, for shorthand, children and young people that go into crisis and need support straight away. And that's why we have a rapid response team.
So the intervention as we go round, the success of that intervention can be seen by the reduction of numbers in each particular quarter.
Yes, so if we more or less, I mean, some children and young people, the thing about the Thrive model is children and young people will be maybe receiving support in more than one quadrant, if that makes sense. So they may be receiving support from the community-based services as well as from CAM. So it's not, the trouble when we put models up, it all looks very clear and stark, but it's not quite that simple. But you are right, if we could support children and young people earlier and build up their resilience, obviously the hope is that we would have fewer children needing the specialist community teams from CAMS, or fewer children needing the anxiety and depression pathway. Clearly there will always be some children that go into mental health.
So are there opportunities for the trust to provide help to the teams that are working, for instance, the schools, at that point, even though we're not taking any responsibility for them, we are helping, as I say, the school teams to provide better support being measured by that intervention reduces the number of children going forward to the next quarter.
So in the East, our Getting Help teams and our mental health support teams actually do that support and do the training into schools. And again, during the pandemic, the teams ran quite a lot of webinars for schools that were very well supported. In the West, that support comes from the same teams that happen to be provided by the local authority, again with our support and our supervision.
Okay, time is running out, John, if I cut you off. Stephen, last question, then we must move on. Thank you.
Stephen, you're on mute.
Right, sorry, 2 questions. Is the helpline free phone or is it paid for? You said about online courses. What support is there for children, particular places like Slough and parts of Reading where people don't have access to the internet? What support is there? And finally, children waiting for referral to join the CAM service, if they then move into the adult service, is there a bridge or some form of connectivity so those children aren't lost in the service? Thank you.
Yeah, okay, so the CPE line is an 03300 number, so it's a free phone number. You're right about the digital online support. It is an issue and concern about digital poverty, and therefore the support will come through the CPE, through our common point of entry, sorry, or our community services in the community. And then your third question was, sorry, remind me.
It's about the transition to adults.
Transition into adults, yes, sorry. We do, yes, sorry, that's a really good question. We do have a transition pathway from children's services into adult services, and we work very closely with our adult mental health colleagues. Okay.
Karen, thank you very much for your time. As you can tell, very interesting, and I know it's a complex problem, but thank you for your time and the work.
Anytime you need me back, I'll quite happy to come.
That's great. Many thanks then, Karen.
Okay, thanks very much.
We'll let you go.
Bye.
Okay, well, thanks so much. I thought a very, very interesting presentation. And I think it's quite interesting. It sort of shows out some of the complexities that we're in with our very fragmented commissioning arrangements. It's not just that I talked about local authorities, but it's also 2 ICSs, etc. So, you know, we've got to find a way of simplifying this so we can allow our clinical experts to get on with their job rather than spending their time sorting out, you know, different requirements from different organisations. Right, we'll now move on, if we may, to staff survey. Jane, are you there?
I am. Hi, Martin. Good morning,
Jane,
everybody.
I don't want to cut you off, but if we want to have a little bit of time for questions, so when we're running a fraction late, only a fraction late, but if you can.
I'll motor through
over
it.
to you.
Yeah, I would just like to say I've also got Steph Mokes here if we have any detailed questions, because Steph is our lead for the staff survey and for engagement. So any questions, please do ask and we'll do our best to answer. I'm pleased to say that we've had another really good set of staff survey responses this year. So we've got around 60% still answering our questions, which is a really good response rate compared to the national average. And I will say that there are some areas, for example, Prospect Park, where we had a significant increase in people taking part in the questionnaire, which is really encouraging to see, because those are some of the areas that we've struggled with in the past. So that means that we feel that what we're getting is quite a robust set of results from people. Our overall engagement score is 7.4, and there's no other combined trust that has a score higher than this. So again, you know, we're topping the tables on that. There's a tiny decline from last year, which is in line with the national average. I think post-COVID, across the NHS, we saw engagement scores dip slightly. Ours dipped less than most, which again is a good sign for us. I won't go through the details, but they're on the slides about how the engagement score is calculated, but it's a set measure based on the number of responses within the staff survey. So you can see again the detail of that on slide 4 in the pack. On the staff survey themes, there are a number of themes. That's again collected questions under certain topics or themes, and you can see that we are above average on all of the themes. And again, compared to comparator trusts, we are the only trust in either of our ICSs where we have such a strong bank of scores, and where we're above on all of the themes. There are 2 themes particularly that have been highlighted with stars here as being the best in class, and that's the one around always learning and the one around staff engagement. So yeah, if you see the ICS comparison again, it's quite detailed here, but you can see some of the results that are coming out from the ICS providers across the board there. And then if you're interested in the regional comparison, those are the comparisons for across the Southeast region. Solent is the strongest performing. Solent, I understand, is a tiny trust, but yeah, there's some really good scores across the Southeast actually, and we're doing well in our responses here. I will say a little bit about the fact that our scores are being recognised. So the health, we've been recognised as the top mental health trust in the HSJ. So that was pointed out, and that's always lovely to see that the media is picking up on our scores and recognising us for some of the good things that we are doing. So these are the areas where we've had some, really great success. Where we're, improving our scores significantly, or where, again, we're getting best in class scores. So there's some really good feedback about the organisation acting on concerns raised by patients and service users. That's, up at in the 80s now, 85%, 86%. That's a really strong score for us. Really very proud of the fact that people recommend us as a great place to work. That's a superb feedback for us in terms of that our staff think that they would recommend it to their friends and their family and to come here and work here. That's always a really significant score that we look at. And we also get best in class for having a set of shared objectives. Some of you may or may not have seen the work that's come through around leadership in the NHS, and one of the things that was pointed out there is have organisations got objectives that link back to the overall trust objectives, and very few do. I'm pleased to say that we're one of the organisations that do that, and I think that then makes it very, when we say that the team have a set of shared objectives, you can see that coming through there. So I think that's some really good scores. We would not, however, be Berkshire Healthcare if we thought that that we could now rest on our laurels and be complacent around those scores. There is still work to do. So we have got some amazing set of results. There's still areas where people are saying that this is an outstanding trust for some, but not for us. Okay, and that is, and there are two main areas where we continue to see some concerns. That's the areas around equality, diversity and inclusion, and work pressures and workload. So let me just talk a little bit about some of the information here. So and what we're trying to do. In terms of sexual orientation and gender identity, we have an unwavering commitment to the Pride agenda, as we've put here. We are delighted that this year we made it into the Stonewall Top 100, and that's the first time that we've been in there. We're one of two trusts locally that made it into the Stonewall Top 100, SABP being another trust that made it in there. But I'm pleased to say we were higher than SABP. We're always rather proud of being better than them, but there we go. We have tried to make this, really an inclusive workplace, and it's nice to see that the work that we are doing to address our levels of inclusion now are really coming through. We look at the workforce race equality information, however, and we still have some real concerns about this here. The number of staff who are reporting that they are receiving bullying and harassment, both from patients and staff, is still too high, and that's not acceptable. We have held some rapid improvement events, and particularly at areas where we know we get the most complaints around bullying and harassment, for example at PPH, the inpatient unit, and really looked at what do we need to do to tackle that, and a series of measures have been put in place. And it's really interesting that I'm receiving feedback from the leadership and the staff there that suggests that it is working. We now send letters to patients to advise them of how we would like them to treat our staff. When they come in, we've got violence reduction person dedicated to looking after staff that have received or been on the receiving end of violence in the workplace. And there's a piece of work looking at how we create more of a culture where people don't suffer bullying and harassment. That's a focus around allyship and cultural understanding, because sometimes we find that a lot of issues we have between people are down to different cultures and different cultural understanding. So yeah, and the other things that we want to be doing in 2022, we're looking again at how do we create more of a sense of inclusion and really support our people to feel that they're included in the organisation. And that's around focusing on making sure we've got a leadership that values and understands how to create an inclusive workplace, having a proper talent strategy that ensures that we are sponsoring and supporting people from all backgrounds to succeed in the organisation, and specifically going out and looking at creating more diverse pipelines into some of the workforces that we have at the moment, particularly the allied health professional workforce, which tends to be very female and tends to be very wide. Again, I can talk a bit more about any of that if we need to do so. The pressures on workload continue, and what we are starting to see is that our turnover has been increasing, and undoubtedly some of that comes down to workload. The turnover across the NHS has increased, and people are increasingly talking about the pressure of work on them post-COVID, as we try to clear backlogs of work, and as we try to also take on and tackle some of the new work that's coming in, such as some of the things around the Ageing Well programme, for example. What we have been doing is a real effort to try and recruit more people, and we have got more staff in post now. We're also trying to work much more closely with NHSP to make sure that we've got a group of trained professionals to come into roles who've got through NHSP. So we're doing a trial for at the moment again at Prospect Park, where again we have a number of our problems, looking at increasing the pipeline of NHS staff by having what we call a try before you buy, or a temp to perm model, bringing people in, guaranteeing them a certain number of hours on NHSP, and if they want to transfer into permanent roles with us, then having that conversation with them. We've also started an international recruitment programme, so we have now got our first international nurses landing in the trust. So it's been brilliant to see the success of that programme, and our next batch of international nurses are due to be arriving in the summer. So that's what we're trying to do around some of the work pressures that are coming up. We continue also to try and support people in terms of their work, looking at having a wellbeing champion network, and we continue to engage with staff about other things that we can do to reduce work pressures. So again, for example, we know that recruitment takes a lot of time up for our frontline staff, our clinical leaders. So we have introduced some on a trial basis, what we're calling recruitment partners, who will take away some of the admin burden from the front line, and also look at some of the hard to fill roles and create new attraction approaches to try and deal with that, using much more engagement on social media, or going out much more proactively to fill roles that we're struggling to fill, which again means that we can then relieve pressure on staff who are covering often for gaps in the workforce.
Jane, are you just about finished? Because I'm keen that
I'm finished. Perfect timing. Yes, I've
Excellent.
finished.
That's perfect. I'm sorry, we just ran a bit over on the first item, but that's fine. Well, Jane, thanks so much. Clearly a lot going on. I'm sure governors will want to quiz you about some of this. So over to governors. Oh, no hands.
I've answered all the questions. That's wonderful.
Stephen.
Yeah. You said about inclusion. Could I just ask, what is the current declaration rate for our trust, and where do we sit within the table of declaration rates, if you will? Because I know there is a table that Stonewall do look at.
Off the top of my head, I'm sorry, I don't know, but I can come back. I'll find it for you and come back and post it in the chat.
Please.
I do know, because it's different for different groups. We have different declaration rates. We do know that declaration rates on ESR are much lower than people and they declare in the staff survey. So when we declare, we do know that there is a number of people who aren't declaring, but I'll get you the exact figures. I'm not sure what the exact figures are, but I'll get that for you.
And also, what I noticed with regards to Slough and, for example, Woking and Reading, they have very different cultural aspects which do impact on inclusion and diversity and equality. So how are you dealing with that cultural aspect with regards to employing and retaining staff in the communities?
Okay, it's a really good point. So the first thing is that when we have got a programme of what we call, which involves allyship and cultural intelligence or cultural understanding. So really trying to understand that different people come from different cultures and different backgrounds, and trying to create a bridge of understanding with people so that they understand, because often what we are doing is we're bringing people in, particularly things like our international nurses, for example, or staff who've come from abroad, been living in the UK for a while, but largely within a different culture, and expecting them to understand how we want them to behave. There's some really good examples we can give of that. If you ever want to talk to me, or if we've got time, and what we're trying to do is create that bridge of understanding that people come from different perspectives. Particularly that power hierarchy that you get in some cultures where they won't challenge. So we're trying to, make people aware that they may be, people will see something and not challenge, or just not be aware that they're expected to do certain, or pipe up or say something in certain situations. In terms of, what more we're doing in areas like Slough, the plan for this year now is that, we do know that there are certain groups that don't think to apply for certain roles. For example, we don't get many applicants from men to do audiology. Martin will like this because he always talks to me about what we're doing to attract more men into certain professions. But we also know that there are certain ethnic groups that don't apply to certain roles, like occupational therapy, for example, or speech and language therapy. There is no reason why they can't be applying. They probably just don't understand that those roles are available or know much about those roles. So what we're looking to try and do within our ED&I groups is to create more contacts into those communities and raise the awareness. So we have got now an early careers lead. And one of the key roles of the early careers lead is to be working alongside system partners to try and access young people before they start making university choices or going into universities, and giving them the opportunity to find out more about these different types of professions. We have just got some money through the Bob ICS to do a piece of work around what we're calling reservist money. And what we're hoping to do with that is use that as an opportunity to give people paid work experience for 12 months. And they could come in, work alongside our staff as almost like paid volunteers doing specific work, like they can clean, like they could, watch people when they're in bays. They could perhaps do a little bit of feeding with training and things like that, but they would stay and they would do some work with us, and work, allowing them an opportunity to experience what it's like in the NHS, and potentially working alongside that, doing a foundation course at a university. So we're in the early days of discussing that and agreeing that, and Berkshire has agreed to be a trial for that in the Bob ICS.
Okay.
Use that to reach out to particular groups as well.
Thanks, Jane. I'm just conscious of Stephen, if you're happy with that. Brian Wilson's got his hand up.
Oh, just a very quick one. How many people are there in the EDI team? Are they full-time? Is it extra to other duties? And are they trained specialists in that discipline?
Okay, yes. So actually my ED&I team incorporates equality and diversity, but also what we call the violence reduction agenda, because violence is often not just about physical violence, it's also about verbal abuse. And they look after talent and leadership, because talent and leadership is part of that work. So the people I have in my team are actually responsible for inclusion and organisational experience, as I call it, leadership, inclusion and organisational experience. Within that team, I have a lead. So we have a lead for that work. Then I have a violence reduction team who who do lots of training, but also a lead on the violence reduction strategy and agenda. Within the leadership team, there should be 4 roles in the leadership team delivering training. There are some gaps there at the moment. And then the ED&I team, currently, we have 3 people. So we have, as I say, the lead overall. I have a deputy for that person, and I have someone who specifically works with the networks and looking at reasonable adjustments to ensure that we've got reasonable adjustments for staff. Does that help you understand?
That's great, thank you.
Mm.
Okay. John Wellham, I think it is, isn't it? So.
Very quick. In the future, I would find it helpful if I understood more of the patient to staff, whether they're being racist or whether they're verbally abusing or whatever, and if possible, if there's any ethnic background to that.
Okay. Yes, we do have records of incidents. The patient to staff violence can depend on what type of patients we have, particularly within Prospect Park. So often what we find is if we get one particularly distressed individual, that there are more incidents with that one individual. We did do some work again at Prospect Park to look at the levels of violence, and it's really interesting. At the time we looked at it, all staff, no matter what their ethnicity, whether they were black or white or declared themselves as an ethnic minority, were suffering violence from patients. So it was irrespective. It may have been greater for some groups, but all staff suffered some levels of violence or racism and verbal abuse. And offences aren't white on black from patients to staff. We also have BAME patients who will abuse white staff as well. That's not, it's not, they're not always got competence when they're doing that. They're not always aware, but some do. If we have got poor behaviours from some people, we will talk to them if they have the capability to understand their behaviour. And we do now have some sanctions in place, which we can put in place where we think the behaviour is unacceptable and the individual knows it's unacceptable.
Okay.
Answer the question, Jeff.
Okay, so I think Jane, thank you very much indeed. Some great results from the staff survey, so congratulations to you and your team. And also it's great to have as we always know we do in this trust, to recognise there's still more work to be done and just get on and do it. So pass on our thanks really to your team. It's a great result.
Thank you. Take care.
Thanks so much, Jane. Okay, we're running slightly late, but Mark Davison, I hope, is here, Chief Information Officer. Hope he can switch his computer on all right. And Mark, are you there?
Hi, Martin. Yeah, I'm here.
Now then, you've got 20 minutes on the agenda. I'd like to have some time for questions, so if you can do your update fairly swiftly, and then we'll have questions and governance. Is that all right?
Okay. Yeah, I'll whiz through it.
Thanks
Hopefully
so much.
you can see my screen already.
Yeah, perfect. Thank you.
Excellent. Welcome, everybody. Hi, as Martin says, my name's Mark Davison, for those people who haven't met me. And I'm the Chief Information and Digital Officer for the Trust. I just really wanted to highlight that we're obviously not coming to a digital strategy from a blank sheet of paper. We're already well ahead of many other trusts in the country in our digital agenda, and we've achieved a great deal over the last 5 years, incorporating digital tools into our wards, our community workforce, and our interactions direct with our patients. We've also already achieved the minimum specification for digital maturity that the Secretary of State, Sajid Javid, laid out back in January. And our core digital infrastructure will meet international best practice for things like internet first services, software as a service based delivery, etc. when we complete our telecoms migration later this year. We're also exporting some of our more innovative digital care delivery tools to other trusts, such as our online guided therapy. Karen Cridlin was talking about some of that in children and young person services earlier, and our digital therapeutic patient networks for things like eating disorders and perinatal mental health, now being used as far afield as Mersey, the Isle of Wight, and more locally in Oxford. And then we've got patient digital access to their appointments and mental health crisis plans, which is also going to spread across the country through our work with one of our suppliers for electronic patient records that many other mental health trusts use. We've also already got a fully mobile workforce and the capability for our staff to work from anywhere at any time. So building on this solid foundation, we've a determination to deliver even more outstanding care and making this organisation a great place to live. So we're well placed, I think, to embark on the next stage of our digital healthcare journey, which continues our progress in digitalisation, moving us from paper records and process to digital ones, automation, which is all about improving and optimising our processes to improve our efficiency and productivity and meet some of our stretch target goals for finances that we inevitably have in public services and in the NHS in general. And still yet more transformation, where we can unlock new value, new ways of doing things by innovating existing services and processes, or creating new value generating services by using techniques that aren't available outside of a digital space. But having said all of that, one eye on digital poverty, one eye on being inclusive across all the different communities. So everything we do at the moment and we're planning to do also has a non-digital equivalent. So there are no digitally exclusive services in terms of our strategy moving forward. I'm just going to very quickly highlight that we've developed this strategy through high levels of consultation within the trust. We've engaged across our different services and built on our previous successes over the last 5 years in incorporating all of the lessons we've learned during COVID, and aligning to the national agendas. Was NHSX, now part of NHS England, looking at what they consider to be what good looks like. There's a whole framework for different staffing groups now published, and what the digital maturity of an organisation. And now there's a big focus on what a health system and health and social care system looks like at both a place-based and an ICS level. So we're continuing to engage in that. So we've been working on this for about a year, and the strategy itself was approved by the Trust Board and Executive in December. So as part of that engagement approach, really, what it allowed us to do was to co-create a set of principles with all those stakeholders, which will shape each project we deliver. And that ensures both the safety of what we do and the maximisation of the benefits we achieve. These principles are challenging. They're not easy in a vertical market using digital technologies with constrained financial resources. But they are essential to unlocking those maximum benefits and delivering safer, outstanding healthcare. It's interesting that this approach that we've taken in this has now been adopted by both of our constituent ICSs for delivering their system-wide digital plans across Frimley and Boxox and Berkshire. So I'm pretty confident that we got something right in that process, which is great. So we've now got a digital vision where we're looking to release more time to care to really focus on that productivity piece, but at the same time improving our population's health through greater interaction with our patients. One of the great things that digitalisation allows us to do is to interact with our patients more often than we possibly can do with the volume of workforce that we have and the number of patients we have to serve. So we're also about giving our patients more choice about how they receive their care, and making it so that people are more able to engage effectively in their own health and well-being. And often that means, what's the latest that is in my notes? What's the latest results of my diagnostics? how do I engage in that conversation with my clinicians from an informed point of view rather than from a turn up and learn point of view. So we're going to deliver this using 3 objectives. So we're going to see and treat more patients whilst improving the quality of what we do. We're going to improve patient access to care and help them to manage their own health. And we're going to support our people to build a digitally ready workforce. So those 3 objectives in a little bit more detail. Why are these our priorities? In an environment of increasing demand and diminishing clinical workforce, we'll focus on releasing time for patient care and replacing time currently spent on admin processes such as recruiting staff or completing forms to communicating with patients and care colleagues and other organisations, taking away all of that unnecessary bureaucracy, but still getting the outcomes we need. So freeing up just 1 hour of everyone's time each week could gain us over 200,000 hours of additional time to care each year. So the saving potential is huge. If you wanted a financial value on that, it's in the order of £5 to £6 million per annum. So improving our digital infrastructure with single sign-on, faster networks and easy access when on other sites is really aimed at improving the working lives of our staff. So people are not waiting for technology, that there's reliability, there's ease of access wherever they have to work to see patients. And enhancing our shared care record capabilities, integrating those records and data across all of our various health and social care partners in Berkshire will ensure our clinicians have the right information at the right time to deliver outstanding and joined up care to our patients. We'll be looking at our population health management with early pilots to provide the trust and the wider health system with valuable learning and understanding of the potential in this area. And we'll be starting with looking at things like suicide prevention and high intensity users of healthcare. So those people with multiple comorbidities and who are being seen by multiple care sectors to see if we can actually, as an ICS and a joined up health provider, deliver some new service that's better for the patient. In our second objective, empowering our patients, we're really looking to empower them to manage their own healthcare and interact more effectively with their health providers, and support the delivery of new models of care, where the patient and their families are able to quickly and easily interact with their appointments. I think most of us have personal experience about how difficult that can be just on its own, with the information in our medical records, with digital advice for self-care of our conditions, and actively engaging and maintaining and even improving their health and well-being whilst they're waiting for our services. I think, again, Karen highlighted in children's, there's an awful lot of effort while people are waiting for services and while they're in between clinical appointments. And there's a huge opportunity for digital to keep people plugged into a healthy roadmap, if you like, a healthy agenda in between seeing their clinical professionals. So we're going to do this by extending the use of our very successful, you may have heard of Silver Cloud and IAPT therapies, but our online therapy services with an ambition to utilise this type of care in all of our settings by 2026. We'll be doing some pilot projects looking at remote monitoring of patients, so that's building virtual wards, you may have heard those terms, over the next sort of 2 years. And we did some fantastic work on COVID for blood pressure monitoring and SpO2 for vulnerable patient groups during the last 2 years. I mean, it's really, how does that apply to a wider set of group patients in the future? But also, how do we enable the earlier discharge of patients from hospital and perhaps prevent the admissions into acute services as well by monitoring people in their own homes? There's a huge amount of learning that the NHS has to do to see which of these services are both safe and have an evidence base as being a better model of care. But it's an exciting time to be in it, I think. In the third area, we're looking to enable our people. Now, obviously, our greatest asset is our staff. And I don't expect, and I don't think any in the executive expect our staff to be digital experts. What we want to help them become is experts in using appropriate digital tools to deliver their outstanding care. We need those tools to be simple to use, and we'll deliver the support our workforce requires, ensuring from joining to leaving, all of our workforce feel confident to use those tools in their everyday jobs. And we'll be working across the trust to encourage a digital learning culture, creating networks to support staff in spreading great practice to everyone. So that's utilising our best-in-class staff engagement and appraisal processes that Jane just mentioned, to support staff in making digital healthcare part of their career development. So these three objectives together reflect our need to maximise the value of our digital investments and ongoing costs, expanding the use of proven digital tools and investing in innovation and things like a trusted research environment to stimulate more clinical research for more of the conditions that our patients are suffering from, to get better pathways of care. The majority of our digital delivery programs will assist us in delivering our health inequalities by reaching out and in some cases targeting those harder to reach groups. Imagine, if you will, the teenager that doesn't want to leave their bedroom. Now we have an opportunity to come into their bedroom, as it will, virtually, and help deliver care to them. Therefore providing more patients with more choice on how they receive and interact with us. The three objectives also reflect the 14,000 odd thought exchanges we received and the feedback from the 300 participants of the focus groups and the Digital by Design Day we held at Ascot Racecourse in the autumn. They're underpinned by a fourth programme of work, which is slightly less exciting in that it's all about the business as usual infrastructure management and development, such as application enhancement, support, faster networks, repair, fast turnaround of equipment, making sure that services are always on 24/7, that training is delivered appropriately, that old equipment is replaced without burdening with the front line with packaging and replacing and all that stuff, updating the applications, delivering analytics and insight, etc. And then interweaving this with our people strategy and our general organisational development activities, so that digital at the end of this period is truly embedded in our culture and services. So together these enable the transformation of our services to utilise and embed digital health in the outstanding clinical services we provide. And I think, just to finish, a very colourful, it's a large roadmap of what we're intending to deliver by outcome. So not a traditional programme plan, that's all embedded in the operational teams, but this is just to keep us simply on track. And we're already at spring 2022, and we've delivered our first HR process automations and our first business automations into finance, and we're starting to measure the benefits of those. But we've already freed up 2,000 hours of frontline staff time by delivering just the first quarter of automation and clinical management upgrades, such as our medicines management solution, which went live in March. So,
oh, sorry, Mark.
So I was just going to say, Martin, that's it from me, I think, really. Over to questions.
Yeah, Mark, thanks so much. Very clear presentation. We've got questions. Ray?
Yes, hello. I recently did a visit to Oakwood Ward at Prospect Park, and two things came out of that conversation I had with staff, which I think may be relevant. One, which was the staff were talking about a system. Sorry, I don't know which one, but they were talking about a system and the merits of it. And they were between them discussing how they use it. Some staff didn't appreciate certain information was available on the system. So the other staff were explaining how useful it was and how they use it, and it's worth investigating. So I thought that was a positive thing to share with you. The other thing, less positive, was they were trialing a patient monitoring system which tells them when a patient gets out of bed. And the units, the sender unit, it raises a page notification when the patient moves. The sender units were getting damaged. They clearly weren't fit for purpose, in that they were in the bed and were falling out of the bed and bouncing on the floor and breaking. But the unit was having to pay £40 replacement costs for each unit damaged. Given that they were piloting this system, given that they were trying to help the developer make it a more robust and sound offering. I found it somewhat surprising that they were financially being penalised for helping out this provider. So I don't know if you have any comment on that, or whether that's your remit or not.
Yeah, so there's 2 Falls technology support systems in the trust at the moment. The one in Oakwood, I think, is falling out of favour. It was liked by a number of clinical staff in a couple of other wards earlier on, and I think it's over time being replaced by another system, which is more of the mat type sensors, so underneath mattresses, so they're not really visible to the patient, and or underneath seat bottoms. I'm not quite sure of the right term for that, but you know what I mean. I think, although we're piloting it from a clinical point of view, from a supplier's point of view, we've purchased and have a contract, and that contract includes things like damages paid for by the NHS. So that's just the way those commercial contracts are done. It actually doesn't sit in my remit; it sits with procurement and clinical governance. But nevertheless, it is kind of normal for that to be that way. I think in terms of the fit for purpose, one of the complexities we have is when we put things which are designed for the frail elderly in a physical health ward into a more mental health setting, we get different requirements. We should be used to that by now, but it still seems to, each new area we go into, it catches us by surprise. Classic being, you've all got a home Wi-Fi box that you're probably plugged into at the moment. When you try to put those into a mental health hospital and take account of ligature points and activities like that, it becomes very expensive, and you need some very, very bespoke engineering and design to make it happen, which takes it a long time.
Mark, could you unshare your screen, please? Just.
Oh, sorry, I thought I had. What do I know about technology? Eh?
Well, don't ask me, but.
Yeah, okay. I think I would just like to say, you know, I hear what you're saying, but I think procurement perhaps should take a new view, in that if you're trialing new technology and it has yet to be proven to be fit for purpose, why should the tester be paying the penalty for that?
Yeah. Ray, I think this is something we need to take outside. I think it's not really full to Mark. So if you can keep your question, we'll try and get you an answer separately. John Wellham.
Thank you, Mark. If I had to choose one word to essentially summarise what you were talking about, it would be logistics. NHS England have recently put forward an artificial intelligence programme, and I'm wondering where our trust is particularly starting to look at that, how they can bring some of it in, how they can learn and predict where things are going to happen, and so they can set this up, whether it be, for instance, predicting that we're going to need certain staff with specific training, and so we can get that in place. But every time I ask this question, it falls on stony ground. I get no answer. So unfortunately, you're right in the firing line this time, and hopefully you'll be able to tell us exactly where artificial intelligence type of techniques are going to be brought into this wide digital program.
Okay, so amazingly, depending upon your definition of artificial intelligence, we've either got lots of it in place or we haven't got any. So where we've got it in place in terms of our decision support in everyday use in prescribing, for instance, so contraindications of other medications and or diagnoses, that decision support is given into clinicians as they prescribe live. Is a good example. There are other examples as well. In our reporting, where we're looking at particular patient groups, we use rules-based artificial intelligence and algorithmic-based artificial intelligence, both of which are essentially, you can define that if I'm this height and this width, I can fit through this tunnel. It's those types of rules, as opposed to what I would, being a Star Trek fan, think of artificial intelligence, which is machine learning. Here's a bunch of people, figure out which tunnels they'll fit through, go and learn how and what the rules might be. We do not do any of that. That's right at the forefront of medical research at the moment. So that's being done by big research institutions, and with lots and lots of backing from very large corporate bodies, both in the pharma industries and in the digital industries, from people like IBM and Bayer and people like that, DeepMind, Google, all of that stuff. And we're not involved in any of those things at the moment. They bring into the health environment a whole bunch of complexities around ethics that we are not well placed to decide upon at the moment. Rules-based is okay, I think, and then we're really starting to push the boundaries of that with our process automation. And when we get into clinical automation, imagine if we triage a patient or get a robot or a computer program to triage a patient, how do we ensure that is clinically safe? So in terms of our digital priorities, going back to, here's our principles, whatever we decide to do must be as safe as having a doctor do it manually. And we have to design that into the technology. That's starting to happen in places. I think it's got a long way to run yet, and I don't think it will be mature in this phase of our kind of digital strategy. I think we'll have very good rules-based artificial intelligence, but not machine learning based in this period.
Okay, we've got people waiting. John, if you can allow us to move on.
Well, very quickly, Martin, if Mark's willing, I'm happy to have a conversation with Mark offline.
Okay, that's fine. Thanks so much, John. Ros.
Thanks. Thank you, Mark. That was a really interesting presentation. And you mentioned about telecoms migration later this year, I think. I've become aware of a number of issues with phone systems. If I could give you just 3 examples, and hopefully you'll tell me this will all be sorted later in the year as a result of the changes. When you phone Prospect Park Hospital, if the receptionists are busy, the phone just rings out. There is no waiting system. There's no way of knowing that you've actually got through to the right place. You just lose it, and you have to keep trying and keep trying and keep trying. That's one. Second one is, on a visit to the crisis team, we were told that staff often have to go out into the car park to use their mobile phones, which obviously doesn't sound ideal for them or for the patients at the end of the call. And the third one is, when calls are made to patients from mental health professionals, and I assume potentially other staff in the trust, it comes up as no caller ID, which doesn't enable people to know who's phoning them, why they're phoning them. And if no message is left, there's no way of getting back to the relevant member of staff. So my fingers are crossed that you're going to tell me all of this will be improved later in the year.
I feel like I'm about to give a 6 out of 10 answer.
Oh.
So PPH first, taking the first question first. PPH is a PFI site. So the telephony there is run by the PFI provider, not by the trust. And under a contract that was set 20 years ago. So you can imagine technology has moved on and that contract has not kept pace with it. Why it goes from ringing to disappearing, I actually don't know, to be honest with you. We'd need to talk to operations at PPH about that, because technically that system is able to run it through whatever hunt groups they like. But I guess if they're only contracted to provide 2 receptionists for answering the phone, and those 2 are busy, and they're not contracted to provide a call waiting service, or there's a limit to the number of people that can be waiting, which is something we've experienced with British Gas and people like that this period, haven't we all? Then there might be something like that. So there's a bit of not included in our main trust telecom strategy because it's a PFI site. but I think there are things we can probably follow up and deal with around that. For the crisis team, mobile phones. Okay, so what have we done positively in PPH? All of the Trust mobile phones are able to do Wi-Fi calling and use the Wi-Fi signaling within PPH. The biggest problem we have within PPH is that some of the secure areas in particular, and things like place of safety areas, the construction of the building is, for the scientists amongst us, a very large Faraday cage, and which means signals just don't get in and out. So there comes a point when there's little else we can do other than enabling that to go over the Wi-Fi signal if the Wi-Fi signal is working, but we do not have 100% coverage in PPH. And we have had Cisco, BT, EE, O2, and all the world's experts in there trying to solve that particular problem. And it just comes down to the building design. On the no caller ID issue, yeah, so this is predominantly driven by clinicians who, or by clinical staff who actually don't want patients to call them back. So there is no reason. So if you look at me when you see me on Teams or you iPhone
I have to challenge that. What is your evidence?
My evidence is that, so for instance, when we put phone systems in, people have the choice. So our Trust staff have the choice as to whether or not they have caller IDs or not. And if they're phoning from their desk phone or their mobile, they turn off that caller ID function. It can all be switched on. There's no problem with it being switched on. But generally speaking, if you can imagine a busy consultant with their phone these days, even just getting 5 or 10 of their patients calling them a day, they wouldn't be able to see their appointments.
Mark, that I've got experience of that in a general practice. That was an issue in general practice, and it was very simply overcome by any caller ID routing the caller to the general number. So the individual clinicians were perfectly protected, but the big advantage to patients is that when you get a random call, many of us screen calls, when you get a random call from an unknown number, you don't answer it. But now with the GP practice having implemented that system, if you do hit recall, it goes back to the general number.
Yeah, and of course with general practice, it's one team, one site. We operate out of 160 different sites, and all with their own reception arrangements, all with their own telephony arrangements. So you can imagine we then have consultants that may work across multiple teams in multiple sites. And of course, which one does their call go back to? I mean, we even have situations in the Trust where we have a building with 2 different services on 2 different floors running on 2 different telephony systems, 2 different receptions, and you can't transfer calls between them.
This behaviour triggers complaints.
Sorry, John? John, did you say something?
Yes, sorry. This behaviour triggers complaints.
Yeah, but there are practical issues here, as I think Mark's indicated, about patients ringing in and getting in the way of a planned list of surgeries. So I think it's quite a complex issue. It's not just a telephony issue, I think. Tom.
Thank you. Just to say, I remember talking to a consultant some time ago who said a lot of their work was writing reports which were based on extensive numbers of other documents. And this was really time-consuming business. We may not have vast numbers of these people, but they're important, and their efficiency is very important. So I wonder if maybe they should be changing their methods, but I don't think we're going to persuade them to. It'll be their professional bodies that are going to help them do that. But I wonder if we can, is there more support they can get in doing this sort of thing, searching documents and histories and getting their documents together, the reports together.
Yeah, within our digital time frame, within our digital systems, where we're talking, say, let's take something simple as an example, a discharge letter to a GP, then all of the pertinent facts are pulled in from all the various solutions, and then they're able to add the small amount of narrative they might require. But if, however, it's a complex patient, that small amount of narrative can sometimes be 3 or 4 pages. So it does vary from one patient to another. I think we have a number of tools to help them, including digital dictation, including transcription, and also including translation services as well, to address the issue that many of those same reports will go to patients and will need translating. And a lot of that in this day and age is automated. Not everything. One of the biggest areas we struggle with is the court liaison and justice service, because of the amount of work and the fact that criminal proceedings are often involved, and therefore there are a lot of legal opinions as to what's allowed and what's not. Right.
Just to say, part of the problem was just handling the large number of documents in the patient history.
Yeah, all of our in our organisation, our entire patient record has been digital since 2015, with the exception of some psychological evaluations, which are, for want of a better word, copyrighted, if you like. You have to fill them out on the form. It's a bit like the Myers-Briggs psychometric test that we might have done as a management person. Those kinds of things have to be done on the same forms, and again, they're all on paper still. So apart from those, everything we do is digital.
Mark, I'm afraid time is against us, but you can tell a very interesting subject for governors, and thank you to you and your team for all the work you're doing. And I see if I can learn some of the new techniques myself, but one day. Thanks so much. We'll let you go then, Mark. Thank you.
Thanks, Martin. Thank you, everybody. Thank you for your feedback as well.
Okay, colleagues, I think I'm going to move item 10, appointment of non-executive directors, terms of office, to the confidential section at the end. And we'll go straight on to item 11, the executive reports from the trust. The time is against us, so I think what we'll do, if we may, Liz, if you've got any particular thing you want to raise, otherwise we'll just assume it's read and have questions from governors, and perhaps the same for Alex on the performance report. So we'll do the patient experience Q4 report. Any questions for Liz?
Hi, everyone. I think the only thing I wanted to highlight, which I know we've covered a lot today, is around CAMS. So looking at the results, you'll see that CAMS had the highest increase in complaint activity. But as you've heard today, a lot of work is going on both locally and nationally to address that. But that was just an area that really stuck out in the last quarter.
Thanks, Liz. Any questions? Ros?
Yeah, just a quick one. Following on from a discussion that we had at the QA group last time, when we looked at an anonymised complaint, and that generated some quite interesting discussions. My view is that one of the most important things about complaints is the learning that comes out of it, and then following on from that, any service improvement. And it's interesting looking at the outcome of complaints and the proportions that are upheld, partially upheld, or not upheld. And I wonder how much learning is taken from those that are deemed to be not upheld. But obviously, the person who put the complaint in had a reason for doing it. And while the trust may not feel that that was valid, for want of a better word, something must have gone wrong somewhere, otherwise they wouldn't have complained. And how much learning do we take from those and relay it back to staff or work with staff to improve whatever it was that led to the complaint?
Thanks, Ros. That's a really valid point. You know, somebody quite often a complaint, even if we find that it's not upheld, an expectation has not been managed, maybe, you know, a level of understanding or some form of communication just hasn't hit the spot. All complaints, regardless of their outcome, are discussed in the clinical divisional PPSQs, so the patient safety and quality meetings, as they're often referred to. That's, like I said, that's regardless of the outcome, because there's a reason why someone was dissatisfied and someone took the time and, quite frankly, the effort to go through the complaints process. When we talk about the outcomes, that's it's quite a crude measure, I suppose, and it's as part of the complaint regulations that we have to record and monitor those and feed them up through NHS England. However, all complaints are an opportunity to learn, regardless of, you know, what we classify a formal outcome to be. But just to give you some assurance, all complaints are discussed at a divisional level with the service leads.
Okay, thank you very much. Tom.
Thank you. I've got a particular point relating to one of the closed complaints on page 62, number 8361. And just to say, when you look at what it says something physical health to be discussed on admission. Now, physical health is, I mean, obviously, when the patient's admitted, the trust is responsible for physical health as well as mental health. And I wondered whether in this case, or whether this is telling us something that the procedures weren't followed, or whether procedures are not sufficiently established or embedded for this always to go right. I just wondered, you know, just whether is there something more to be learned from this particular complaint.
Tom, what page of the pack is it?
62.
Thank you very much.
Number 8361. I'm just looking at the single line, physical health to be discussed on admission.
So it's about halfway down on that page. It's in a dark blue colour and it's Reading. And it's for Bluebell ward.
Yes.
Yeah, perfect. Thank you. So absolutely, there is learning that we have to take. Whenever we admit someone to a mental health ward, physical health is absolutely, you know, part of the whole person, isn't it? And I think in this case, there was absolute learning around that point specifically that for the staff that are on duty during admission.
So this just was procedure not being followed, is that right? Yeah. Okay, thank you. Yes. Okay.
Anything else for Liz? Okay, Liz, thanks very much.
No, thank you.
You got off lightly today, but I'm sure governors will come back to you.
As always, let me know if you have any other queries as they come up. Thank you all. Take care.
Thank you, Liz. Bye-bye. Sorry we're rushing on a bit, but Alex Gill, performance report, and well, I will just come back to item 9, which I skipped inadvertently earlier. But Alex, anything you want to particularly praise?
Thanks, Martin. We'll take the report as read. I think some helpful updates in Julian's chief executive update there. Performance is looking good against our national targets. Finances in a good place at the year end for the last financial year. We're moving into a challenging financial outlook with efficiency requirements coming back on after the pandemic. But happy to take any questions.
Tom.
You're on mute,
Tom. You're on mute, Tom.
Cover my screen. That's right. Just to ask how we're doing with the ICS coming in on the 1st of July. We've got the board seems to be set up and so on, and there's stuff on the web about that, but we don't know much about the next level down, the places and all that. Do you know anything about where we are with that, and does it really affect?
So in Bob and Frimley, we have the integrated care boards forming on the 1st of July. Their responsibility is for the health commissioning. We know that the integrated care partnership is the wider partnership with local authority and voluntary and community sector. So lots of structural focus at the moment, appointments being made into that commissioning board, the integrated care board. We have the Berkshire West Place, which is well developed. Julian chairs the partnership group there. We have a good set of flagship priorities that I think we're keen as the Berkshire West Place to ensure we're enabled to continue from the oversight ICB and ICS to continue the good work there. Frimley, I would say, is forming its connections and approach in terms of the components of the ICS, which is the integrated care board, the provider collaboratives, and the places, of which we have 5 within Frimley. And actually this Friday there is a place-based development workshop happening, so I'll be able to report more attending that on behalf of the trust on Friday. So we're big focus on the ICBs and now the kind of strategic connections to places, which, as we know, are the local authority geographies usually within the ICSs, and where the health and wellbeing strategies are being able to take primacy from a place perspective. So early days on how it all connects together, Tom.
Thank you.
Ros.
Thank you. Just a quick question in relation to the data on out of area placements. And I know this is included in each report, and I can't remember previous figures, but I think it's always quite high. And my question was really, has the Trust got enough inpatient mental health beds, or are more needed? And what's the sort of overall plan for the future?
That's a spot on question, Ros, and we commissioned a piece of work across our region with our partner provider organisations, with Surrey Borders and Oxford Health, to determine the population demand projections over the next 5 years. That report's in draft. We expect to take that through executive board in due course. But it's not just whether we've got enough inpatient beds, is the community system working effectively, and what has been the impact of the current state of coming out of the COVID pandemic and the backlog and pent-up demand. So there's a number of factors we need to assess before we determine whether we have the right number of beds. Now, the out-of-area placements is a symptom of major pressure on Prospect Park at the moment, and if you switch the number of bed days there, we generally have 25 to 30 patients placed outside of Prospect Park Hospital. It is a symptom we really need to address, and there's work in progress to do that from a strategic perspective, because we need to answer that for the next 5 to 10 years and forward.
Thanks very much.
Thanks, Ros. Tom, have you got another question, or was it a...
Yes.
Go ahead.
Just to ask how COVID is impacting staff at the moment.
Yeah, so we can see in our sickness rates, we're slightly over where we'd want to be, and nationally, COVID is still affecting our staffing capacity. We're seeing some uptick in COVID infection and impact on inpatient admissions again. So we're just keen to understand, you know, what's a normalised view of COVID and its impact going forward. In comparison to other trusts and other units, we're not too bad at a 4.5% sickness rate, but it does impact operations. What is really good is some of the infection prevention and control regime has not been relaxed, but it's been adjusted to account for the fact that COVID is calming and normalising. So we're now able to not wear masks in non-clinical areas. This is some really good reconnecting coming through just by removing masks. And there are we're asking services now to get back to normal operation, so reducing the impact of COVID-related infection prevention control, still being safe, and we've learned a lot of good stuff around IPC, but getting back to normal operations so we can tackle the backlogs and get ahead.
Thank you.
John Wellham.
Very quick, just following up from Ros. Her question about the number of beds. This is exactly the type of question that artificial intelligence machine learning can help support.
Very good point. And we're using predictive analysis. We're using population projections, ONS, and your conversation with Mark will be a good one, John. Thank you.
Okay, Alex, I think we probably exhausted the questions, so thank you very much. Can I just go back to 9? We just got a few minutes. Item 9 is the committee reports, which I'm afraid I missed in my rush to get on. Rather than go through them, are there any particular key issues the chairs of those groups would like to raise? We've got the reports, we've read them. I don't think we need to go through in detail. Tom.
Thank you. Just to say that we got I raised a point in relation to Reading community mental health teams showed on the waiting list report that we saw showed that 60% of people were waiting over a year, which seemed very disturbing. And my question was kindly forwarded to our new Chief Operating Officer, Mina, who gave a very full answer. And it turned out that the figures include not only the community mental health teams, which there are people waiting longer, but there are some reasons, but also what's it called? not clopazine, something like that.
Clozapine, Tom.
Clozapine, sorry, yes,
annual clozapine review.
Annual clozapine reviews. So people were waiting a long time because they were on an annual cycle, and so these figures had been included with the CMHT with figures. And I think this shows that we are just gradually, with these very informative waiting time graphics that we're getting, we're just gradually debugging. There are some, you know, Tamina said she'd go back and see whether these two could be disaggregated and so on. So I think we're raising some queries, we're getting some, you know, we must understand that there are things were still to be sorted out, and we're getting good information, you know, on the whole. Just a few things to sort out. So I think that's just to reassure people from the remarks in the report, and just to reiterate that visits, there's a good system now for supporting governors in getting to visits, and a number of people have been going. They're very rewarding, and invite anybody to get in touch and go, you know, get engaged with visiting services. It's a very rewarding activity. Thank you.
Thank you, Tom. Got a couple of minutes of any comments from membership or Living Life to the Full, which the governors, I think, will need to think about, you know, how they want to take Living Life to the Full forward, because it's with John Barrett going, it's an opportunity just to review, I think, what you want to cover in that. But Tom again.
Sorry, just to say that Living Life to the Full, for me, I've learned an enormous amount from it, and the great value was that it dealt with the relationship of patients with organisations outside the trust, often, and this now ties in with some new stuff that's happening. I was at a meeting a Reading meeting of the Mental Health Wellbeing Group that reports to the Wellbeing Group in Reading, and there's a whole group of people who are sort of going to be reporting in on the aims of the Berkshire West Mental Health Wellbeing Strategy for this adult mental health. So I think that there's an obvious tie, and for me it was just learning about things like recovery colleges, how CMHT worked, the voluntary organisations, Sport in Mind, many different young people with dementia, many organisations. I think it was very valuable in that sense for me, in putting the trust services into a much wider context. I think really helpful, and I think if we can keep that going in that sense, I think it really would be very valuable.
Thanks, Tom. Well, I think it's a matter for governors to, you know, consider and decide what you want to do. I'll support you, whatever you want. Okay. Then item 12 then is just feedback. If anyone's got anything particularly, but otherwise we'll move on. Any other business from anyone? No. Date of next meeting is the 20th of July for the joint non-executive directors and council of governors. And now we'll consider the resolution to exclude the press and public from the remainder of the meeting due to the confidentiality. So if I could ask